Hello, everyone. Thank you so much for being here with us today. While we discuss a few housekeeping items, I'm gonna be asking you all to share your name and where you're from. My name is Paola Diaz. I'm the Outreach and Engagement Manager for the Hispanic Latino Behavioral Health Center of Excellence. And I am very excited to be here. And we are going to be talking about Latino boys and men with eating disorders. Before presenting our guest, I'm gonna be discussing the housekeeping items. Dr. Bono, yeah, perfect. For simultaneous interpretation, or to hear today's presentation in Spanish, please go to the Interpretations tab on your Zoom panel and click Spanish. You can also mute the English speaker's voice by clicking Mute Original Audio. Para traducción simultánea a español, presione la pestaña de interpretación y luego presione Español. También le aparecerá la opción de silenciar el audio original. Today's event is being recorded and will be made available publicly through our website and other media channels. For today's webinar, all participants will be muted. If you would like to speak or ask a question live, you may raise your hand and you will be given the access to unmute your microphone. Please make sure your computer speakers are turned on and up to hear today's presentation. If you're having technical issues, please send a message to the Hispanic Latino Behavioral Health COE on the chat box. If you have a question for our presenter, we ask that you use the chat or simply type your question and hit send. We can address questions to the presenter at the appropriate time during today's presentation or at the conclusion. We will be sharing today a copy of today's presentation in PDF format through the chat box, and we will also make a copy of today's presentation available to be downloaded through our website. You can find it under the name of today's event. A recording of today's webinar will be posted in our YouTube channel. Now, please, we ask you to complete the evaluation. The evaluation will keep us or help us know more about your opinion and thoughts about this presentation. And what other topics and trainings would you like to see offered? A link to the evaluation will be shared through the chat, and you can also scan the QR code at the end of the presentation to complete it. You will receive a certificate of attendance by email approximately 1 week from today. Please remember to check your junk folder. Now, today's event, oh, right. Our mission, I'm sorry about that. Our mission is to advance and support the sustainability of behavioral health and promoting community-driven, culturally grounded, and person-centered prevention, treatment, multiple pathways of recovery, and recovery support for Hispanic and Latino communities. And we strive to accomplish this mission through the development and dissemination of culturally informed, evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health workforce that serve the Latino communities. Now, today's webinar is in collaboration with the National Eating Disorder Association, NEDA. We sincerely thank NEDA for their continued partnership and collaboration in advancing awareness and support around eating disorders with our communities. Their expertise and dedication have greatly enhanced collective efforts to foster understanding, prevention, and healing within communities. The center really looks forward to continuing this meaningful collaboration to create lasting impact together. NEDA's mission, they are a nonprofit organization working to fundamentally change the way eating disorders are understood and treated, so those affected can achieve lasting recovery and well-being. NEDA does this by providing communities with education, early intervention, and funding groundbreaking research through campaigns like Eating Disorder Awareness Week and through their Campus Warriors program and NEDA Cares events. They work to increase public understanding of these complex disorders. They provide information and resources through the Grace Holland Cosine Resource Center, as well as through their educational programs like the Understanding Eating Disorders presentation and monthly skill building webinar. Additionally, they promote early interventions through their screening tool, available in English and Spanish, which has helped over 1 million people. They also invest in research that help to develop effective treatments. Now, we're almost there. Before we start, this is going to be a group discussion today. It's going to be more than just providing information. And I want you all to keep this in mind. This is a safe space for everyone to share their ideas and experiences. We encourage open and honest communication. Please be respectful of others' approaches and experiences, and we all come from different backgrounds and have unique perspectives. Feel free to consult on clinical challenges and share your clinical achievements. This is a collaborative environment where we can all learn from each other. And please be cautious not to share confidential or identifying information about participants, clients, or patients because privacy is paramount. All right. We are going to be presenting Dr. Douglas Bunnell. He is a clinical psychologist and eating disorder specialist in Fairfield, Connecticut, a fellow of the Academy for Eating Disorders. He is currently a senior clinical advisor for the ERC Pathlights programs. Dr. Bunnell has written and presented extensively on the unique issues of men with eating disorders. He is a co-editor along with Dr. Mango Main and Dr. Beth McGilly of Treatment of Eating Disorders, Bridging the Research Prize Practice Gap, and the recipient of NIDA's Lifetime Achievement Award. Thank you so much, Dr. Bunnell, for being here with us today. I know you can share a little bit more of what you do and who you are, and also you can let us know a lot more of the today's topic.
Again, thank you so much, and thank you so much for the Center for Excellence for inviting me to contribute and participate in this. I'm actually looking forward to hearing the discussion much more than I'm looking forward to hearing myself talk about some of these topics. But I'm going to sort of start with sort of the basics on what we think we know about men and boys with eating disorders, and then speak a bit about how I think there's some unique issues for Latino and Hispanic men and boys. But I'm really eager to hear about the experiences you guys all have in trying to actually deliver care to people with these sorts of concerns. One of the things we've learned, certainly working with men and boys in general, is that often those boys and men may be in treatment for a variety of other sorts of behavioral and mental health issues, and the eating issues sort of are lurking in the background. And one of the things we find is just helping people learn how to ask questions and be a little sort of sensitive and vigilant for how these issues may show up in men, because they tend to show up a little bit differently, or even not even a little bit, significantly differently sometimes than the way they would show up for women and girls with eating disorders. So my disclosures, I am a paid consultant for ERC Pathlight. I do get some royalties from the book that we just discussed, but other than that, I hope it's clear that I'm not promoting anything here. Just as we get started, I'm going to go back and forth and probably slip into some language that may be confusing at times. I may, in terms of talking about gender and sexuality, and but also in terms of men versus boys, males, and then certainly I'm going to go back and forth probably naturally between Latino and Hispanic. So I'm going to try to be mindful of that, but please be aware I may slip back and forth, and sort of, if it's confusing, raise your hand or send a question. Just as we get started, I think this is very clear to most people, but most of what we know about eating disorders, and this is what we've learned over the past 40 to 50 years since eating disorders really got on the radar screen as something that was, more than just a unique issue for a couple young Caucasian girls in the upper classes of the United States. But virtually all that we know about eating disorders is still based on the research and treatment of women and girls with eating disorders. So we're actually, when we're talking about boys, working to adapt, boys and men, working to adapt what we know about the experiences and outcomes and just the perspectives and language we use to describe eating disorders for women, how they actually do need to be shifted when we're talking about what's going on for men. Virtually none of the research that we have right now is really nuanced enough to tell us much about the full gender continuum. So I'm going to end up being pretty binary here today in terms of talking about males versus females. There is increased interest in the gender continuum, however controversial that may be in the current environment. But we do know that there are different experiences and presentations of eating disorders and disordered eating symptoms across the full gender continuum. And hopefully maybe in the discussion, we can get into some of those nuances. So if I'm unclear at all in the language, or if I'm confusing you with my psychobabble, please stop or raise your hand and we'll try to address that. And it looks like we have enough time, hopefully enough discussion to get into some of the nuances of this. I will say, just as a general background, I've been working in this field for nearly 40 years now. Because I am a male in the field, I'm still a bit of rare. Most of the clinicians these days are female. So I disproportionately over the 40 years have seen more men than with eating disorders than some of my colleagues. That's not to say I've seen a great deal of them. So I don't want to sort of oversell this, that men are still not showing up for treatment. We're not detecting them. We're not diagnosing them. We're not referring them at the same rates that we think they're actually struggling with these disorders. So there's a lot of stuff going on out there for men and boys that we're just not seeing in general. Most of my career has been working in actually providing treatment. I also have run a couple of national treatment programs, tried to work at higher levels of care, residential, partial hospital programs, to try to figure out how we deliver consistently high quality care. And then for this topic, how we actually adapt that care and those protocols for men and boys who have these issues. So I'm going to start off with a couple references and resources for you guys. And this is one article that came out just a couple of years ago, and I just highly recommend this. This is in the reference section as well. If you want to get a pretty current update on eating disorders in boys and men, here's one book, or article rather, and we'll link to some other resources as well. This is a wonderful book, Eating Disorders in Boys and Men. And within that book is a chapter by Emilio Conte and Eva Trujillo on cross-cultural considerations in Latin American boys and men. So again, much of what I'm going to speak about today in terms of Latino, Hispanic boys and men will be reflected in some of the stuff that's in these chapters. And I think there's a bit of a literature on this, not an extensive literature on this, but that's not to say that these aren't significant issues in many Latin American countries and European countries. So be aware and be sure that even if you're not seeing boys and men with these issues, they're likely out there. And when we get to issues, and this will be reflected in the case we'll end up discussing, when we speak about boys and men who are living in multiple cultures and societies, meaning they may spend time in Latin America and Central America and the United States, for instance, that process of shifting back and forth between cultures and societies and countries turns out to be a pretty significant risk for developing an eating disorder. So I'm sure none of you are particularly surprised by that, but if you'll read about this in the literature on Latin American boys and men, just to speak to that specifically. But I think we underappreciate the impact of shifting cultural groups and the impact that has on mental health in general, but also the power to sort of light up an eating disorder. And I have a lot more we could say about that. Maybe I'll sort of bookmark that for the discussion later on. But if that piques your interest, please go ahead and ask a question about that as we get into it, because I think that's one of the more sort of obvious sort of precipitants sometimes for mental health issues, but also particularly for eating disorder issues in boys and men. This is a relatively new article that came out. Highly recommend this, and eating disorders in Latino boys and men, the role of sociocultural context in identification, assessment, and treatment. Much of what I just said you'll find reflected in this article as well. But what struck me is that there actually is quite an increase in the literature on this over the past 4 or 5 years even. So it gives me some confidence. This is the glass half filled part. Gives me some confidence that we're beginning to understand that these disorders, eating disorders, affect a wide range of people, boys, men, obviously girls, women, people who are, on the gender continuum. And then at a class level, one of them persistent, and it's still out there. I'm not sure how old this audience is, but I'm pretty old. The persistent myth has been that these are disorders that only affect upper class white women. And that is so not true. There's nothing else that you take from this. Be aware that these issues hit every class, every race, every ethnic group, and they show up differently. They have different sort of symptom constellations and presentations and even sort of language or descriptors. But this stuff is going on everywhere. And we still sort of underappreciate that. And even if you'll allow me this, even when we talk about eating disorders, and I'll get into this a little bit, if we're only talking about the formal eating disorders that we see in the US DSM-5, for instance, or the ICD, the International Classification Manual, if we're only talking about things like anorexia nervosa, bulimia nervosa, binge eating disorder, ARFID, there are two other ones, pica and rumination, that are sort of footnotes we don't talk much about. But in terms of the actual behavioral disorders, that is only the tip of the iceberg. And there's lots of data now to suggest that there are many, many, many people out there who don't meet diagnostic criteria thresholds for formal diagnosis of an eating disorder, but have significant levels of disordered eating, over exercise, substance use in the service of body image change, and very high levels of clinical impairment, even without meeting the diagnostic threshold. So expand your definition of what constitutes an eating disorder to include significant levels of disordered eating. And that could be restricted eating, overeating, purging, laxative use, substance use, over-the-counter substance use, all sorts of other ways of managing behaviors, and the psychological impact of living with a persistent, what we've sort of lumped into calling food noise. You'll hear a lot about that these days. Food noise being just the constant internal dialogue about what I'm eating, how I'm eating, what I should be doing, what my body looks like. Is it good enough? What does it mean if I gain weight? What does it mean if I can pinch this on my body? That kind of constant chatter in one's head does damage. It gets in the way of, certainly joy, happiness, experiencing pleasure, relationships, job function, school functioning. It's a big drain on someone's well-being. So the scope of this issue is much broader than you might think just from the literature on the formal disorders. So here's where the dry part, so bear with me, but just to follow up and give you some numbers on these issues. As I said, the vast majority of research we have on eating disorders is based on the experience of women or females with eating disorders. I think, I'm confident about this, that grossly underestimates the true scope of the problem. In fact, up to 1 in 7 people with eating disorders are male. If you look at community samples and you broaden the definition of eating disorders a little bit to some of the stuff I just mentioned, we actually find that up to 1 in 7 are male. And that may be particularly in less represented groups. So we're not getting the same quality of detection in less represented groups, meaning people of color, lower economic groups, people who don't have access to conventional behavioral healthcare or healthcare. So all for obvious reasons. So I think men and boys have been hiding, I'd say in plain sight, but maybe not quite so plain. There are estimates out there that 5 to 10% of all adolescent boys have an eating disorder, 2% of adult men there are surveys or there are studies that suggest that. And homosexual men are thought to only represent 5% of the total male population. This is the US base. Um, but among men who have eating disorders, up to 42% may identify as gay. So two important points there. One of the barriers for men to come into treatment for an eating disorder is this myth that if they have an eating disorder, they'll be perceived or labeled as being homosexual. As rigid or biased as that may sound to people, if you listen carefully to your patients, that's something they will often still talk about. I want to say that's less true now than it was, say, 10 years ago. I'm not so sure that's true. But it's certainly a barrier to treatment. But the flip side of this is that most men with eating disorders are, in fact, heterosexual. So it's certainly not just that if you have an eating disorder as a man, you are likely to be homosexual. But there's something about being homosexual that confers some risk for developing an eating disorder. And perhaps in the discussion, we can get into some of that. But my bet would be that a lot of that has to do with bias and stigma and things like that. And there are other nuances we can get into. Now, within Latino populations, the most common eating disorder behaviors are in the OSFED and BED spectrum. And again, I'm not sure to whom I'm speaking here in terms of your familiarity with some of these eating disorder terms, so bear with me if I unpack this a little bit. But there are the formal eating disorders that we talk about: anorexia, bulimia, binge eating disorder, and ARFID. There are two main other categories. One is the otherwise specified feeding and eating disorders, OSFED. The other one is UFED, which is unspecified feeding, eating disorder or eating disorder behaviors. And essentially, those are categories of behavioral symptoms, emotional symptoms, and so forth that don't neatly fit into the existing criteria for anorexia and bulimia or BED. But the point here, really, just for most clinicians working in the field, most of the eating disorders you're going to see for men are more in the sort of unspecified or otherwise specified category, or in the binge eating category. So less anorexia, although it does exist and it is significant for men, less bulimia nervosa, where you have both the binging and the purging. Here we're talking more so overeating, and then sometimes compensation for overeating, for binging, in terms of exercise and things like that. So think predominantly about men with eating disorders as likely to be coming to you and showing up in your offices, your programs, as struggling with binge eating, but not just that. And again, I'm not sure where we'll get into this, but if you're not familiar with eating disorder treatment, one of the core treatment sort of non-negotiables, really, it's like an essential core of treatment for any type of eating disorder, is to reestablish a regular pattern of eating to help people move past periods of under eating. If you have anorexia, that's sort of obvious that you need to help people increase their eating. People with binge eating and bulimia nervosa are often under eating in a way that promotes the overeating. So it sets off, an impulse or creates increased urges to binge eat, which creates a cycle of under eating and binge eating. And one of the core parts of treatment, almost any treatment you can think of for an eating disorder, is going to focus to some extent on helping people change that pattern so that they're not bouncing between under eating and overeating. Right? So just make that point here, and we'll probably end up coming back to that. We do think that the existing research suggests that there are lower rates of eating disorder behaviors in Latin America, but those rates increase when people move to the US. So when you actually track people as they move from Latin America and relocate or shift back and forth to homes here in the US, there's shifts in a variety of things. The nature of the food that we'll talk about, sort of the nature of body image ideals, the way food is sort of seen within families. There are a bunch of different dynamics that we think may explain this, but there is something about moving from Latin America to the US that actually increases people's risk for eating disorders. That's male and female. In the US, almost 13% of Latino adolescents report some eating disorder behaviors, right? So the white US, the white male in the US rate is only 8.1. So you could make the case that Latino boys teens are at some greater risk for developing eating disorder behaviors, not necessarily eating disorder diagnoses, when they move to the US. And just to hit this again, Latino men have higher rates of binge spectrum behaviors compared to other ethnic racial groups. So Asian or people moving from Asia to the US and so forth have lower rates of developing binge spectrum behaviors than Latino men. So curious to hear what other people think about what might help us explain that. If I had one topic to focus on for this whole thing, and there's a lot to cover here today, if you think about men and boys with eating disorders, and this is writ large, not just for Latino and Hispanic men, but men, boys in general, there are tremendous stigma and barriers that get in the way of people actually accessing care. We have the public messaging about eating disorders that, number one, males don't have eating disorders. If I've heard this once, I've heard it 1,000 times, like I can't have an eating disorder, I'm a boy. Only girls or women have these things. They're female diseases. Most men, this will shock people, most men, if you tell them that they have an eating disorder, will feel some degree of shame or some sense of like they failed in some way, or that they're revealing some weakness. So that certainly women can feel that too when they hear that, but there's something almost shameful, if we can call it that, for men sometimes than actually acknowledging that this is an issue that they're dealing with because they're not supposed to have it, right? The diagnostic criteria that we use, the DSM-5 and even the ICD, are gendered. It's better. Like before we changed it several years ago, we still had amenorrhea, the lack of menstruation or cessation of menstruation as a diagnostic criteria for anorexia nervosa. Well, that was not terribly relevant for men. So there are still sort of embedded gendered aspects to how we describe and diagnose eating disorders. I hope we can talk about this in the case discussion, but the nature and language of treatment, I'm talking here mostly about psychotherapy for people with eating disorders, is pretty gendered. Again, it's rooted in what we know about women and girls with these disorders. Most of the body image language that we use, most of the core motivations in terms of fear of weight gain or fear of being fat or fear of being too big. Actually, those are things that often describe women's experiences or females' experiences of their eating disorder, less so with boys. And we're going to talk a fair amount about how boys and men have a very different, often set of core motivations for their eating disorder behaviors. But if you think about your average boy who may have eating issues, gets referred into treatment, someone says he should see a therapist, he sees one of you guys, or he sees a dietitian, eating disorder dietitian, and that clinician launches into sort of a standard description of eating disorders, standard assessment of eating disorders. Somewhere in the subtext of that communication will be, I'm describing things and asking you questions that are rooted in a view of how women experience these disorders, and it may not quite match up with what the boy experiences. And so just think about what the implication might be there to implications for treatment engagement or premature, departure or discharge from treatment. So this is a little fuzzy, and maybe we can get into it in the discussion. But one of the things I try to teach clinicians is I'm trying to help them adapt what they do to work with men is to be mindful of the language they use and really sort of be a little skeptical about some of the terms and concepts. Right. And I should have said this perhaps earlier, but the main treatment for eating disorders remains psychotherapy. So there's nutritional restoration, there's a role for medication often, but the main treatment is psychotherapy. And one of the main issues for psychotherapy is helping people stay in therapy and make use of it for long enough to actually get better. And if we're throwing anything into the mix that actually makes it harder for people to engage, we're actually, not helping people recover. So it's important to pay attention to language. What are some of the variables you need to consider when you're talking with a boy or a man who may have eating issues? You know, it's sort of most of what we do as mental health clinicians is still reduced down to make sure you're doing a whole biopsychosocial assessment, but the psychosocial should include some attention to, what are the cultural issues at play here? If you think of someone moving from Latin America to the US, are there different perceptions or ideals, cultural ideals of what a body should look like? Like what's we think about the thin ideal for women. Is the thin ideal common or consistent across all cultures? No. And for boys, men, the thin ideal is usually not actually what folks are aiming for. There's sort of a different body ideal, but that varies by country. And there even varies within regions. So what may be true for Argentinian boys and men may be different for Colombian boys and men in terms of, what the preferred body ideal is. And as a clinician, you need to be somewhat aware or sort of up to date on what some of those differences might be. Here's a take home. You can't possibly know all that. All you can do is be culturally sensitive and humble enough to ask. And so, again, I can't see the audience. I don't know who I'm actually speaking to, but as a man working in a field that's largely, female, most of the therapy I've done has been with women. What do I know about what it's like to grow up and feel like a woman? The only thing I can do is to sort of convince somebody genuinely that I'm interested, that I want to learn, that I think it might be relevant to talk about, what it's like to live in a female body. And I want to hear that. And I want you to tell me what I can do to make it easier for you to talk about that. I'd apply that same paradigm to trying to figure out what any given individual's cultural endowment is in terms of cultural dynamics around their body ideals and things like that. Like, be curious, be respectful, be culturally competent enough to sort of know at least some of what you're doing, but be thoughtfully open to hearing and being taught. Same issue here for sexual orientation. I mentioned that there's a higher risk for different sexual groups. And I think clinicians need to sort of actually be culturally competent in addressing that. And then there are subcultures, and we can get into some of these, but certainly the dynamics and motivations, pressures that men and women, but men in this case, feel around athletic issues, like what kind of body do they need to succeed in the athletic endeavor they're committed to? Is that a pressure, or is that influencing the way they eat and the way they experience their bodies? What sexual group are they in? Are there, preferences for thin bodies versus, larger bodies? A much more salient issue than any of us really appreciated 5 years ago is food security or food insecurity. This ends up being one of the leading drivers of binge eating in many populations, but particularly in populations that actually are food insecure. So one of the things that increases dramatically someone's risk for developing binge eating disorder is an experience of food insecurity while growing up. So that certainly is something we need to be embedding and integrating into our assessments and finding ways to talk about that. And then the unique stressors, I think, would be some of these cross-cultural, like transition issues. Like what happens for you when you go back home to Guatemala if you're living in LA? What are the differences? What's that like for you? How do people change? How do people's perceptions of your body affect you differently? Right, so this is actually there's surprisingly strong research on this, and people tend to sort of go, oh, this feels a little fuzzy or even politically correct or something. But the adoption and sort of internalization of hypermasculine norms, and this is a whole discussion, and again, we can sort of move this on to the group discussion later if it makes sense. But there's pretty robust evidence that people, and I'd say men and women, who score higher on rating scales of masculinity and masculine norms actually have a harder time recovering from an eating disorder. So to the extent that a man or a boy is really sort of taken on some of these, sort of conventional masculine norms and really sort of, is really living in them. So there's a competition for dominance, there's aggression and violence, there's sort of biases, particularly about weakness and even a fear or devaluation of the feminine and women, an over-prioritization of emotional control and physical control, and this idea that muscularity and strength signifies masculinity. If you bundle all that together and you really buy into this, can you see how this is actually going to load people with the risk for getting caught up in pursuing body goals and tweaking their eating and exercise and substance use to actually push for those changes? So one of the ways in which a therapist, clinician can engage, particularly their male patients, is to ask, and again, I'm thinking mostly this would be a female clinician asking a male patient, tell me what it's like to be a man, or what, how do you understand what it's like to be a man? And if you can sort of get a discussion going on this and then pivot, and you have to do this in a way that feels like it's genuine, not just sort of pro forma or routine, is to say, I'm going to make fun of it a little bit. It would be like, have you ever thought about how some of these things might affect the way you feel about your body, or how it affects the way you exercise, or how it affects the way you react when you eat a certain food? Like, you actually sort of become curious about those connections, put it into the discussion, and see if you can help your patients actually start to connect those dots. So again, this is something that maybe we can come back to in a bit. All right, a little more nuts and bolts, like symptoms and behaviors. Eating behaviors that we tend to see in boys and men are, as I said earlier, more often focused on overeating and binge eating. We'll see increased levels of exercise. We'll see dietary restriction, and I'm deliberate in saying that rather than like, calorie reduction or dieting, because dietary restriction is not just like I'm going to cut back on what I'm eating. I'm going to clean up what I'm eating. There are types of eating. There's going to be the restriction that goes on in your head. So it may not be reflected in what you actually do with the eating all the time. It's more like you're thinking constantly about, I should be doing this differently or better or more in a more disciplined way. So restriction is both a behavior and a cognition, if you will, or a motivation. And this is where a lot of clinicians who've been trained to work with women sometimes sort of miss the connection with men. Because if you come to a male patient and sort of talking about their, are you afraid of gaining weight? Or you say like, is your eating disorder in the service of you losing weight, which is sort of a conventional interpretation of why people would be cutting back in their eating or trying to cut back in their eating. Most men, not all, because some men have pure anorexia that's almost identical to what women have, but many men are not pursuing their eating disorder behaviors to achieve weight loss. They're trying to make their body look different, particularly around, a lean or muscular or fit or strong sort of image, not a thin image. And just that little shift, in language and focus can make the difference between a patient getting that you as the therapist understand their particular eating disorder versus having a sense of, she's just, or he, in my case, he's just sort of running the playbook here in terms of what happens for women. This isn't what happens for me. So just sort of showing your male patients that you get that it's not likely to be as simple as I'm trying to lose weight. There's something else going on here, can actually build engagement and commitment to treatment. So I say body image and body dissatisfaction is gendered. So we're not talking about thinness usually, just in general for men. We're talking about leanness, maybe decreased body fat, increased muscle definition, things like that. Sometimes more like strength and bulk. So there are eating disorder like constellations that men get caught up in that are more around I'm not big enough, not I'm not small enough or thin enough, I'm not big enough. And it pushes them to overeat, it pushes them to use over-the-counter, sort of weight gain and muscle enhancing products. And actually is a pretty dangerous constellation of symptoms because it can lead people to ingesting things that are really quite dangerous. Sometimes it's a little hard to tease out whether that's a body dysmorphic or muscle dysmorphic sort of thing, independent of an eating disorder. But often the core motivations and maintaining factors are similar. Like I can't be okay unless I, change my body. And if I can't change my body, I can't be okay. So that ends up being, it's the same focus in treatment, but a different sort of interpretation in language. So what's the difference, or some of the differences, I should say, with men versus women? Men tend to have histories of pre-illness higher weight. So they, many men will come into their eating disorder and into eating disorder treatment with a history of having been overweight. I will say, and I don't think I put it in here. Oh, I do. No, never mind. Men will often report losing weight in order to avoid weight-related medical illnesses found in other family members. I'm thinking more so around older men or adult men or older. Like I have any number of middle-aged male patients who have been binging, have been, they've had, medical issues associated with being overweight, or at least correlated, won't be caused, but correlated with being overweight, and have been sort of ignoring it, but are finally sort of convinced to go into treatment when someone else in their family had an issue with say, diabetes, for instance. Often men will find their way into treatment because of some athletic focus or motivation. The onset for their eating behavior or eating disorder behaviors may occur post-injury to defend against muscle loss. You think of an athlete who all of a sudden can't train because of an injury, becomes quite concerned about what's going to happen if he doesn't exercise as much, and will start cutting back on his eating, which will then provoke the binge eating, and then they could be off to the races with that. I wanted to just mention this a bit earlier, but almost every, if not every man I've ever treated with an eating disorder will tell me at some point, without a lot of prompting, that they were teased about their bodies growing up. And the teasing, this will not surprise you, the teasing is often around like, they're too soft, too weak, too girl-like, for an adolescent boy still, it's one of the worst things you can call them is a girl. Not saying that's the way it should be, that's just the experience. But I think it's almost, if you're seeing a boy or a teen or a young adult with an eating disorder, look for experience of teasing, and which at some level, again, this is a whole discussion, could be almost, for some boys, it is so significant an injury that it's almost a trauma that they're stuck with. And it sometimes takes almost a trauma focus to actually help people back away from it or weaken the power of it. Boys and men will discuss their motivations and body concerns in unique terms, again, around the leanness, the muscularity. I want to be cut. I want to be defined. I want my muscles to pop. I want to be bigger. They're not going to say commonly or conventionally, I want to be smaller, I want to be thinner. And all of you know, because you're mental health professionals, that the way men express depression and anxiety, the common comorbidities of eating disorder, can be quite different. So the language, the risk for suicidal ideation, and so forth, are different. And so I probably should have hit this earlier, but a lot of the differences in male eating disorders parallel some of the differences in the way men express depression and anxiety, and particularly around the use or the risk for substance use as well. I've alluded to this a couple times, the drive for muscularity. This is not uniquely an adult problem. In fact, one study found that 90% of teenage boys exercise for the purpose of bulking up. So teenage boys, and probably as social media infiltrates everything we think and do, um, boys are finding their way to, you know, sources that tell them that they're not good enough unless they bulk up, and they're just as susceptible, I think, as girls have been historically to messaging that they're not good enough unless they get thinner. Up to 60% of all boys report manipulating dietary practices in pursuit of muscularity. So again, not necessarily the level of a formal eating disorder, but there's a lot of body image distress out there amongst boys and men. Muscularity-oriented eating is often a key driver of eating disorder behaviors. So we've touched on that already. And just, I talked a bit a moment ago just about some specialized or small groups and the different dynamics, but these are sports that may have some increased body messaging and pressures that it's important for us to pay attention to. Sort of touched on this. I may not spend too much time right here, but muscle dysmorphia you can think of in terms of a variation on body, but just body dysmorphia basically. But it's sometimes hard to tease this apart from an eating disorder. These folks are particularly susceptible to the use of steroids and growth enhancement products. And this is less of an issue. We don't see this issue as often with girls and women, but for boys, if you've got someone who's struggling with these sorts of issues, have in your mind that there's some increased risk here that he's going to find his way to GNC or find something online or find something in the gym in the weightlifting culture to help him actually make the changes in his body that he wants to make. And that can be from just wacky over-the-counter things to actual steroid and testosterone injections. So you want to be aware of that and be sure you're at least sort of, asking questions about that. I haven't said much about ARFID, and we have as great a data on this because it's still relatively speaking a newer diagnosis. And if people aren't familiar with this is avoidant restrictive food ingestive disorder. So these are people who, the common image is that they're picky eaters, but often they're really significant sensory issues. And these are people who will restrict their eating, can only eat certain types of food, small amounts of food, may actually lose weight, may look like they have an eating disorder in terms of being driven to pursue thinness or body changes. But it's really almost more of an anxiety disorder. And the treatment's food, as it is for all the eating disorders on some level, but the actual psychological treatment is different, and it's often for these folks more common to what you do for OCD in terms of creating exposure and response prevention sorts of opportunities to help people increase their eating. Not everyone, but more often not, well, the gender rates for ARFID versus the other eating disorders for male versus female, more common for boys to have ARFID than it is for them to have another type of eating disorder. Right? And the earlier onset ARFID patients tend to be boys. So this may be a separate talk, but I think if you're a practicing clinician and you're seeing boys who are picky eaters, who are not gaining weight because they're not eating enough, this needs to be on your diagnostic sort of radar as well. Again, I'm not sure how relevant this is for most of the folks here today, but I'd make the point, I'm a psychotherapist, obviously, so I get to see people when they come to me when they've got sort of emotional distress. Men and boys may end up showing up to medical treatment before they show up for psychological treatment because, going back to the barriers and stigma, they may actually not be referred for treatment. They may not sort of know they have an eating disorder. So they may actually be pursuing their behaviors or caught up in the behaviors long enough for it to become a medical problem first before it becomes a noticeable psychological problem. So there are some medical issues that are a little bit unique to men with eating disorders beyond what we can talk about here today. But for behavioral health clinicians, be aware that often men and boys may come to you more fragile and vulnerable than some of your female patients. That's a broad statement, and people can pick that apart. But think of it in terms of like boys may not get to care till they're really far into it, and so sometimes they're like in more urgent state than women and girls. If there are nutritionists or dietitians in the audience, there certainly are adaptations for men and boys based on weight goals, their energy requirements, the growth expectations. Similarly, the language of eating disorders that you use in your nutritional therapy need to be adapted for men and boys. And you also want to I learned this from a colleague who actually was both a psychotherapist and a trainer, and he kept emphasizing the culture of the gym culture is quite interesting for boys and men, probably for girls and women as well. But in terms of the crazy, wacky sort of sort of fringe nutritional advice you can pick up in the gym, and I'm not sure I have any specific examples, but eat this for 3 months and then don't eat that for 5 months and you'll be fine or your body will grow. There's some pretty wacky stuff out there. You can't keep track of all of it. So again, as a clinician, you have to be sure you're asking, like, what do you know about nutrition? Who taught you about nutrition? And this, you can do this as a therapist, psychotherapist, but also obviously dietitians need to understand what info do their male patients have about nutrition? What have they learned about it? I've talked about exercise, but this is an important focus of any assessment for a boy or man with an eating disorder. Their motivations for exercise and compulsive exercise are less likely attached to weight loss goals. They're focused on muscularity and leanness. And the exercise, the compulsive exercise and eating disorder motivations may be disguised by socially acceptable expectations regarding training. So I'm not sure if this is everyone's experience or perception, but I do think still, and I think it's changing, but we tend to validate and really sort of admire men's commitment to over-exercise, and we might be a little less admirable or admiring of women's commitment to exercise. So sometimes men can get away. Men can sort of overtrain in the service of their eating disorder, but have it look like it's still like they're really disciplined and committed. So that's an issue to just be aware of as a clinician. You be sure you're not sort of buying into that. It actually applies to the binge eating issue as well, because whereas if a woman is binge eating, we'll sort of be more likely to see that as problematic than if we think of a 19-year-old boy binge eating, where it may get dismissed as, well, that's just what boys do. And again, I'm not recommending that as an attitude. I'm saying that's sort of the culturally sort of, I don't know, I'd say different sort of perspective on what's normal or acceptable for men. So we do think the rigidity of exercise routines may be an important maintaining factor for males. So if you're not sure, you're working with a man who's exercising and you think it may be part of his eating disorder, you want to sort of find out what it would be like for him to interrupt that routine, because it'll be in the interruption that you find out, okay, what happens if he can't do that? Is it okay? If it's like, I missed that, I wish I could, that's one thing. If it's, I was so distracted I couldn't function the rest of the day, then you're on to something. Certainly comparable rates of substance use disorder to women with eating disorders, but a higher rate of over-the-counter substance use, and again, often for growth enhancement, things like that. So there's a formal term for the appearance and performance enhancing substances, the APES. And you do want to at least ask about steroid use if you have any sense that your male patients are exercising or pursuing muscle development. All right. So I'm going to pivot more to some of the Latino and Hispanic issues and concerns that I think actually you can layer into or weave into some of the basic stuff I just outlined. But if you look at some of the resources, and I've talked with my colleagues and my somewhat limited experience with some individual patients, Latino patients, these are some of the issues and themes that show up. And you'll see many of them are the things that show up for boys and men in general, not surprisingly. But there are some important ones to sort of be thinking about if you're working in a Latino, largely with the Latino population, or particularly with a Latino population that's shifting back and forth between US and home. So you will find the cultural issues of machismo frequently mentioned in the research, and these are in sort of the surveys and in the, there are, not surprisingly, scales to measure this. But if we go back to the issue I made about masculine norms, to the extent that machismo is somehow reflective of a pretty rigid credo about how males should function, there's good evidence to think that that actually is going to help. Well, not help, it's going to get in the way of people actually being able to let go of their eating disorder or some of their eating disorder behaviors. Family obligations, what I'm trying to get at here, and I think what the literature gets at, is that there are commitments to taking care of family that may revolve around feeding and eating and cultural expectations about what men are supposed to do with their families with food, that if someone's binge eating may actually, I'll say influence the way they approach their eating disorder. So think of all these issues, not so much as like these are facts or these are things that definitely going on for any one individual. These are the issues that you as clinicians want to have in your head or in your sort of playbook in terms of what are some of the things that may have created this man's boy's eating disorder, and more importantly in my book, what's keeping it going? What are the pressures that we're going to help him manage once he's stopped the behaviors? What are the things that are going to trip him up or make it harder for him to actually stay well? Healthcare barriers is just, can he access healthcare? And can he access your services? And what gets in the way of that? I mentioned food insecurity earlier. If you grow up in a way where you don't know where your next meal is coming from, I mean, if put it that way, or you're insecure and unsure of where that's coming from, it creates an expectation of both psychologically, but I also think biologically, like if there's food available, I need to eat it. And that can be a bad reinforced cycle. Right? Latino food, if people aren't clear about what I'm saying there, I don't think I explained it very well. Let's come back to that in the discussion, because I do think this is an area that we're sort of developing our awareness of what it means and how pervasive an issue it is. But I'd love to hear your perspectives on this. So I do think, again, I'm going to need to learn from you on this, but I think the nature of the what are the preferred foods in any given culture, and if you're shifting from one place to the other, are there different food preferences? Even at sort of the macronutrient level, are there more carbs or protein or fat, in different cultural food preferences? And how do people navigate those shifts when they move from place to place? I think just straight up the stressors of adapting to a new environment, new language, new body ideals, the whole thing are things we need to pay attention to. That they're going to show up expectably when people travel back and forth from, again, say LA to Guatemala or wherever they're traveling to. You want to understand at least a little bit about what men and boys know about treatment. I make this point, it's sort of true, I think, but maybe not entirely, that most women these days, if you say, do you know anything about eating disorders and eating disorders treatment, they'll say they know something. Most men, I'm going to argue, maybe it's changing a little bit, most men won't know that. it will be sort of a surprise to them that there's something called an eating disorder. And they really won't have much background or sort of knowledge about how to treat those disorders. So I think you have to sort of really get a read on what they do know. And that could be as simple as just asking, what do you know about eating disorders? Would it be okay if I told you a little bit about them? Treatment access, I mentioned. Job-related food restraint. This is a colleague mentioned this one to me, and I hadn't thought of it, wasn't in the literature, but it's a colleague who works largely Latino population, said for a lot of men, they are not eating during the day because of job expectations. They may be sort of just not, they don't have access to food during the day. What do you think happens in the evening? Right? So they're likely to overeat in the evening, and that can create, if it cycles, into a pretty significant binge eating disorder. So that's something you want to be aware of as a clinician. There's this whole concept of cheat meals. Cheat meals would be like, I'm going to be good all week, but then I'm going to allow myself a cheat meal. A cheat meal often would be like the really delectable, highly palatable foods that you haven't allowed yourself to have. And often they may be, I think, for some men, the sorts of foods that they're not allowed to eat here, but they would be allowed to eat at home or back in their country of origin. Anxiety is the prominent affect that men are going to sort of show you the anxiety and sort of irritation, maybe more than like direct concerns about their body. And again, this last one, or next couple came from my colleague again. The shame about eating alone was something she'd noticed in a lot of her male Latino patients, just that there's sort of a cultural expectation that you be eating with other people, but sometimes when they move here, they end up feeling like they're often eating alone, and that leaves them vulnerable to a number of these other issues. And I think I've touched on these other two, the nutrition at home and the body image disparities at home and school. So I know we need to move to discussion pretty quickly. I've probably overdone the didactics here, but and you will have access to these slides one way or the other. So these are some of the published assessment options for men with eating disorders. They touch on a number of these different issues, from the body dysmorphia, muscle dysmorphia, and then the straight up eating disorder behavior scales. And then there are a couple that are clearly, they're developing a good sort of a database for Latino or Hispanic populations. So these have all been validated for use with Spanish-speaking populations. So the CHI is the Children's Eating Disorder Attitudes Test. The SCOFF is a screening, it's a 5-question screening test. So, if you only have a moment, you'd want to go with that. The EDEQ is sort of still the gold standard, basically measurement questionnaire for eating disorder behaviors. And then a couple muscle related ones. Again, all these are available and validated for use with Spanish speaking populations. I'm going to wrap up quickly, but one of the persistent issues in the field in general, so across male and female eating disorders, is that we still don't have a consensus definition of what recovery means. So there's like the basic requirements that people stop binging, purging, starving, over exercising, but we don't really have a sense of like what else needs to be in place to be sure someone's fully recovered. So we don't really know that in general. We have smaller research based on treatment outcomes for men, although right now you'd have to say we don't really have any evidence that the outcomes are any worse for men or for women, that they're about the same. It is sobering though, and I want to sort of just put this out there, that only 50% of men or women seem to remit and recover with their existing treatments. Now you can sort of quibble that with that. There's some debate on like, how are we measuring that? But the conventional sort of consensus now is that we don't really have treatments that get everyone well. We have treatments that do a great deal and are very helpful for, let's say, up to 50% of people, namely cognitive behavioral therapy, enhanced version for eating disorders, and family-based therapy for kids and adolescents. But there's a big chunk of people out there who don't do particularly well with our existing treatments. So we need to keep refining those. And I'd leave you with this as we pivot to the discussion. Is there a way to think about a focused on the gendered aspects of treatment that would help actually improve the odds that a man or a boy would find treatment helpful, would stick in treatment, would sort of, really solidify his recovery, with enough treatment to actually be solid in that, if we pay attention to some of the gendered aspects of treatment in terms of how we conduct therapy with men and how you as clinicians engage with your male patients. So maybe we can talk a little bit about that.
Hi, Dr. Bunnell, we already have a question in the chat box. Would you like me to read it?
I think I saw it. Go ahead and read it just so everyone hears it. Yeah.
Yeah, of course. It says, do you have any guidance on addressing differences in perspectives between Latino male teens and their parents?
I think that's a great question, and I just saw it 10 seconds before we just heard it. So I'm thinking as I speak. Well, a couple things that come up. I mean, this is an issue that's hard, regardless of whether it's a male female issue or probably certainly not easy sometimes or oftentimes even in non-Latino. I mean, sort of in the U.S. But when they're cultural, so they're age issues in terms of talking to parents, there are cultural issues potentially in talking with parents as a clinician, trying to help them understand why their teenage boy may be struggling with, let's make it up, struggling as JR hears with feeling overweight and sort of dealing with that by over exercising or taking over the counter steroids, things like that. I think you have to be thoughtful and gentle with it. But the message you want to be reinforcing is that their son, if I'm talking to the parents, has a psychological issue that is real and painful for him and is not something that you can just sort of dictate away. So what I see with parents often, this is not by any means just with, in this Latino example, it would be oftentimes adults who don't know much about eating disorders may sort of see this as an issue of discipline, control, like, why can't you just change this? They get frustrated, they get angry, they get sometimes irritated. That can lead sometimes to just criticism and, harshness, which never seems to help anybody change their behavior. Like at this point, I mean, this is a bit of a joke, but you all know this, like your first stop is to tell someone, well, you probably shouldn't do that. But once you've said that and things haven't changed, there's really not much upside in continuing to say you really shouldn't do that. You need to sort of move to your plan B. I think sometimes having just that kind of discussion with parents can be helpful too. Like, you're going to have to do some education. You're going to have to help them, like the parents I'm talking about now, find resources that help explain this to them. It may be helpful for them to speak with other parents if you ever have that option who are dealing with it. But I think the key issue is to help the parents understand that not only do they have their son, in this case, really needs their help with it. If to any extent they feel like they are responsible for it, you need to sort of actually push against that and really help them understand that this is something that happens. There's no evidence that what parents do actually creates their child's eating disorder, but they can have a big role in his recovery and treatment, and you want to work with them. So if you're talking with parents of a teen, particularly with an eating disorder, you should be doing more than talking with them. They should be part of the treatment. So you want to make sure you've built in a mechanism for working with them routinely, not just a one-off sort of, here's what's happening, and then I'm going to work with your son. But I'd love to hear from other people if we actually have that capacity for other people on the call to talk about like what would you do with that? You've got I'm going to make it up. So let's imagine you're working with a young adult or teen, but his parents are not in the town you're in, or you can actually meet together with them. You have like one or two opportunities to talk with them. What do you want to say to them? What do you think would be important for you to convey to those parents? So Graciela says their parents may need to be educated about eating disorders. Absolutely. And again, I would assume that or presume that most parents, particularly of boys, will not really understand how their son could have an eating disorder. So you can have to do like not just your basic eating disorder education, but sort of like your, gendered, adapted explanation on how, yes, in fact, boys do have and come ready with the data and ready with resources and really sort of help them understand it. I find the analogy to, and other people may have other analogies that make more sense, but like to help parents understand it as an anxiety disorder, sometimes sort of at least gives them a paradigm for understanding it that may be more common or familiar for them. Like it really causes him psychological distress. It's not just about food and eating. So again, people can see the comments, I guess, that I find it difficult for parents sometimes to get that these behaviors and thoughts are not totally in the teen's control. That's so true. They have questions about why they can't just change or stop that. So that, as you know, is hardly unique to issues of Latino men and boys with eating disorders, but that is a very common family reaction. And if I always tell clinicians, so I'm telling you because you're clinicians, like you have to work hard to put yourselves in the shoes of your patient's family members. Like we want family members to understand that their kid, male or female, is struggling with an eating disorder. And that, that's a real thing and we have ways to treat it and so forth. But understand that most parents who haven't read about this or aren't familiar with it are going to wonder what the heck's going on here. Why can't he or she just eat? And the variations on the theme, why can't he or she just eat, are endless. But it often leads to parents being frustrated and hurt and angry. Often they feel powerless. Often they feel like they've done something wrong. So that's a pretty toxic mixture of uncertainty and guilt sometimes that makes it hard for folks sometimes to be empathic and supportive. And most of the harsh reactions you see from family members are usually rooted in fear and anxiety. And if you can sort of come to it with that from that angle as a clinician, it sort of helps you not get caught up in like, the parents are being angry or controlling. They're just frightened. So yeah, it's explaining mental health issues to Latino parents is hard enough. I can't imagine. So this is the advanced explanation. Right? So I'm, I can, for whatever reason, I'm not able to move my slides now because oh, thank you. Thanks. So again, I'm going to go ahead with a case description here, and again, to whatever extent we can, I'd much rather hear your questions than sort of talk to you. Again, I can't see any of you, so it's always, the remote presentations are such fun this way. But you'll see I've tried to capture some of the issues here. So JR in this case is a 19-year-old man from Mexico City. He's the eldest of 4 children, lives with his middle-class family in Mexico City. He comes back and forth to the US frequently, or did as a child, to visit extended family members. He's now decided to move to the US to live with his aunt and uncle and is planning on going to university in California. So what do we see here being teed up as some of the issues, some of the stressors for this guy? So he's with He's in a different city, even though he's somewhat familiar with it. He's going to live in Southern California. Um, well, I sort of give it away, but let's say California in general. So again, without sort of being too crude about it, Southern California or California is sort of you think about if you're going to pick one community that's going to really promote a thin body and fit body ideal, that would be like you know, the core of it. So certainly moving into an environment where he's going to be flooded with messages about what a body should look like. And certainly flooded with information about how he should be eating and sort of not eating. So let's presume that he is a little homesick, he's struggling, he has some anxiety and sort of sadness, maybe is struggling to function a little bit, his sleep's gotten worse, or yet his temper's been bad. Somebody suggested he seek some treatment at the college counseling. He felt embarrassed and ashamed about that, resistant, but he did go to see someone at the college clinic. He finds his way to a non-Latino, non-Spanish speaker counselor through his school who thinks he's coming in because he's sad, angry, and anxious. His grades are slipping and he feels like he just doesn't belong at the school. So what are the issues that perk up your ears here in just that paragraph? All right, so I just sort of, point out that he's the counselor. I mean, this is again pretty pretty blunt, but he's working with a counselor who doesn't speak Spanish, is female, probably doesn't know that there's an eating disorder lurking here. So Sylvia says, lack of building rapport with counselors if they're not culturally competent. That I think that's a significant issue. And I think even, I'll go back to what I said earlier. I think the most important thing you can do as a counselor if you're mismatched in that sense and any dimension, whether it's gender, eating disorder issues, cultural background, country of origin, any of those things, the most important thing you can do is to acknowledge it and be curious about it and convey to the patient that you want to understand their experience, that you're eager to learn, not to be taught, not for your benefit, but you humbly understand that these are significant issues that you may not be able to speak knowledgeably about, but you want to learn. And I feel like that's in some ways, I think that helps on a number of levels. It alleviates some of the pressure on you to sort of be up to speed on everything because you can't possibly be, but it also sends a message that you're not just sort of going to tell people what to do. You want to understand their reaction and their experience of what you're suggesting. And it decreases the power difference. And one of the key things I think in working with men and boys is, and again, this could be gendered as well, is a man working with a male patient, there's sort of, particularly obviously as an older man at this point, I get some credit immediately for being, whether I deserve it or not, being sort of experienced and wise and powerful and that stuff. And that has some benefit, but it actually gets in the way as much as it helps. So I think this sort of move to a position of trying to be an active collaborator and depower things a little bit can be very helpful. So like if you're a woman working with a man, often some of the, the flip side may be true where you're perceived as not being knowledgeable, not as powerful, you won't get it. So you may have to work harder to convince your male patients that you do get it, in the sense of saying, look, I don't understand this necessarily, but I want to hear what your experience is. And I'm just looking at some of the chat questions. Like Crystal asks, what are some evidence-based practices can help a young male who is struggling with an eating disorder and cannot continue to therapy, minimize it, help him cope through this in a healthy way? That's well, I'm gonna go off on a tangent then on this question a little bit. Maybe we'll see if we're smart enough to bring it back to the case. But well, one way I could bring that to the case is even when someone's finished with their therapy, psychotherapy, however long they're able to be in that, or, whenever they decide to stop, there are things people can do and that you can help them do that will solidify their recovery. So a commitment to a regular pattern of eating. So this is sort of the evidence-based practice that's at the key core of almost every eating disorder treatment is, can you help people reestablish a regular pattern of eating? What that means is eating essentially every 4 hours something. And in the phased approach to it, it's like you don't really care at the beginning what people are eating every 4 hours. You can move to food variety and things like that later on. But if you've got someone who's not eating all day, then binge eating at night, which is sort of a pretty common sort of pattern for particularly men and boys, um, then you want to move to help them. What can you eat for breakfast? What can you eat for mid-morning snack? What can you eat for lunch? What can you eat for mid-afternoon snack? Then dinner, maybe an evening snack, because you want to avoid the, you know, I undereat, I binge eat. I undereat, I binge eat. That's the cycle we're trying to interrupt. So anything you can do, from food records to app-based work to um, working with dietitians, using their smartphones to actually for reminders. There are a number of things that you can be that are available, but then you can then be creative in developing for each individual, like what's going to help you remember that you need to eat. That's interesting. So Sylvia, I don't, can I out you and ask you, can you say a bit more about that? A lot of self-evaluation as counselors as well. So this is actually a particular interest of mine, and it's not related specifically to working with Latino boys and men, but um, working as a psychotherapist in the eating disorder field is challenging. And I think, I mean, I guess every specialty says that, but I actually think that there's some unique aspects of working with patients with eating disorders around the medical acuity, the scrutiny, the measurement of progress, like, oh my gosh, my patient's still binging, purging, starving, over exercising. I must be a crappy therapist. That sort of doom scroll loop that we can get into is, it can drain you. So it's really important that you obviously you get consultation, you get support, you get more training, and you find a way to sort of really stay grounded in, like, you can only do what you can do, that the responsibility for change is not squarely on you. And that's the existential dilemma for psychotherapists, is like, how much of yourself do you put on the line to help people sort of deal with their pain and make changes. One of the challenges with working with people with eating disorders is that um, even though we think it'd be a great idea for them to change what they're doing, sometimes it's really hard. Oftentimes it's really hard to do that. And oftentimes there are compelling reasons that people have for not being fully on board with changing. And you have to respect that. And some, it can be as, deep and specific as, like, um, they have a trauma history, and their eating disorder helps them manage some of the trauma activation stuff. So if you are going to have them change their eating disorder behaviors, they're going to be flooded with the trauma related stuff. That's a sort of obvious example. But we're asking someone to, well, I'll try to bring it back to the case, to move from Mexico City to California and fit into um, the culture that he's trying to sort of fit into. And we're trying to help him tolerate having a body that he feels is inconsistent with doing that. It'd be great for him to not continue to exercise and binge eat, but if the price he has to pay for that is he's going to feel like he doesn't fit in and he's being shamed and critiqued and criticized, um, we have to really work hard to respect that and accept with equanimity that we can't compel anyone to do this if the price of changing is too great for them. So there is a lot of self-evaluation as counselors. The other thing comes up with working with people with eating disorders, if you have the resources and the good fortune to do this, is you're often working in a team. So you may be collaborating with a physician, with a dietitian, maybe with a psychiatrist if there's medication involved. You're doing family therapy, perhaps, and your individual therapy, perhaps. There are a lot of people looking at what you're doing. So most of our individual work, we're not getting scrutinized that much by our colleagues, but there's sort of like an open assessment of what's going on and how good your work is when you're working with patients with eating disorders. And it can feel challenging sometimes to actually feel like you're doing an okay job. So I think the self-evaluation thing's an interesting issue. What about guilt in patients? Well, where do we go with that? There are all sorts of ways to go with that. I would wonder for like JR in this case, like what, I'm going to guess that when he's home in Mexico, he feels like he's not doing it right. And when he's back in LA, I put him in LA. When he's back in LA, he also feels like he's not doing it right. So wherever he goes, and I think maybe this is the key to it, he feels like, he doesn't quite belong. He's failing on some level. And, that actually is pretty painful. One of the issues my colleague brought up to me, and when I was talking with her about this, she said, and I think I put it on the slide, but I put it in a way that didn't really explain it very well, that many of her patients she's mentioned, when they go back home to say, again, Guatemala or wherever they go, their family members and their peers criticize them for having lost weight and sort of for their pursuit of the fit ideal that made sense in LA. They actually get criticized and teased for sort of buying into that when they move home. So actually going back home ends up feeling not like a relief, but just another challenge and test. Sylvia elaborated. Thank you, Sylvia. In order to build rapport with clients, specifically in a diverse community, we need to be able to do a lot of self-evaluation as clinicians about our biases, biases, perceptions, stereotypes. To help clients, we need to understand how they're perceiving us. Yeah, thank you. I didn't really sort of focus on that, but I think I was trying to get at this a little bit earlier, just like we come in with all our own biases about men versus women, about Latinos versus non-Latinos, and I, some ways, I think one of the more important things we can do as therapists is to own up to that and non-defensively, but genuinely and openly sort of say, yeah, like I'll give you an example. Like I would say I'm working with a young adult woman, say, starting with her at some point early on in the treatment, and I'm talking about within the first, let's say 10 sessions, I'm going to find a way somewhere, somehow to say something like, it strikes me, it's, I know it's got to feel a little bit weird for you to be talking about this stuff with, at this point, me, an older white man. And I want to just be sure you hear from me that I understand that could be a little weird. And I want you to know that it's okay to talk about that. And if I sort of get some sense that she might be open to talking further, I would add something like, and I think I would say to her now, and I think sometimes some of the things we feel about, what men are supposed to be, what women are supposed to be, has a big impact, not just on treatment, but on impact on how people's eating disorders work. Have you ever thought of that? Or is that you ever think about that connection? And we used to do that more frequently back in the heyday of feminism in psychotherapy, which tragically I think is sort of diminished a little bit. We used to deliberately ask, like, what do you think it is about being female that contributes to your eating disorder? I want clinicians to feel like they can find a way to ask and not make it sound like a textbook question, but like a real, like in the moment question. How do you think your sense of what it's like what you're supposed to be as a man might be affecting what we're talking about in terms of your eating? So I want to weigh again, Sylvia, a little bit from your self-evaluation, but I think you're absolutely right. it's incumbent on us to do our own work to be a young adult patient, female with binge eating disorder. She's doing quite well. Has been in a relationship with a non-binary partner who uses they as a pronoun. I know this is sort of a little controversial to talk about these days, but in therapy, I would, because I am who I am, I'd keep talking about her partner as a her. And then I'd stumble and I'd sort of like find my way to use the they pronoun. And I finally said, look, to my patient, I'm going to screw this up over and over again. I need you to know you can call me on it and it's okay. And, it's not your job to call me on it, but go ahead and let me have it when I do it because I'm trying to work on this. That opened up everything. She's absolutely fine with that. Now routinely, I got way better at it, so I don't do it as much. But giving her permission to call me on it actually sort of took the air out of the issue. And I mean, that was some small example, but I think that sort of openness to it can actually help you sort of, well, actually get at the very issue, but also sends the message that you're open to that sort of feedback. And I think one of the, we're sort of off the topic a little bit, but actually one of the things that helps people in therapy, at least the people I've worked with eating disorders, is to have a sense that what they think and feel actually has an impact on other people, because often there's this sense that they can't have an impact on other people until they get their bodies just right. But if you give them an actual experience of, having an impact on you in therapy and the way you conduct yourself in therapy, it may be a small thing, but it actually, can have a big impact and actually creates sort of a buffer to the eating disorder a little bit. Like if I have a confidence that my opinion and feedback matters, maybe I'm a little bit less concerned that I have to look a certain way, weigh a certain thing, have my abs pop or anything like that in order to be meaningful and credible. Let me see if there's anything else in the case that I think needs particular comment here. But so I obviously developing his upper body and arms. The focus on abs is pretty common focus for boys and men. And you'll hear language around body fat and even measurement of body fat. JR here, I mentioned he was a bit overweight and stocky as a boy. So he's probably getting teased about that a little bit, but that again sort of reflects that many boys come to treatment with a history of being a little bigger than average. So they carry with them that sense that if I don't really work hard to keep that from happening, that's what's going to happen to me. Well, people have the case in front of them. What other questions? I think that's actually one of the questions on one of the slides is, what other questions would you have here about JR? And if you were, this young man walked into your office and wherever you may be, what's your opening comment or, your opening sort of session like with him? Or actually, just to frame it this way, what questions do you want to ask him? Oh, nobody can change the slides. So. That's all right. I mean, that's fine. But who figured that out? Thank you. We almost made through the whole thing without a technical issue, but all right. Well, I don't want to get distracted by this. I'm curious what other people have to say here. So let me just, we've got about 10 minutes left. I'd love to hear your questions, feedback, any concerns you have about this. What are the things you'd hope to get from this today that I didn't touch on? And be happy to answer any of your questions. Doing this sort of work to build connections between what did I eat in one column, was it an overeating episode in one column, and then what was I thinking and feeling? And doing that work over and over again helps people build the connections between. So, gosh, look, here's the pattern. I didn't eat all day. I binged at night. I didn't eat all day until I got home from work or school and was starving and ate a bag of Doritos. Um, then I felt crummy about it, committed to not eating the rest of the day, woke up the next morning, didn't eat, and then binged again that following afternoon. And you start up, that's a pretty obvious pattern. But you want to have ways for your patient to share that kind of information with you. And there are increasingly online ways to do that. There's some apps you can use, but I think it's straightforward CBT to do that. Now, I just full disclosure, don't at this point routinely do CBTE with people just because I feel like I can have a conversation about these issues and start to build a connection where we're collecting this information in a similar way without the worksheets. But when I was younger and just learning how to do this, I would use the tools that are out there. Get the worksheets, use them, bring them into session, find a way to sort of, use them collaboratively. I mean, figuratively, maybe even literally with your male patients, move and sit next to them at a desk to work on a shared project together. So you sort of dodge the issue of like he's in there to talk with a therapist about his feelings, because that may feel less familiar to him. So moving to that more collaborative mode, which can work for many patients, not just males, but I think can be very effective, particularly if you're a female patient, a clinician working with a male patient, to sort of emphasize the collaborative nature can help minimize some of the issues around like, oh, I don't want to be vulnerable in front of a woman stuff. All right, what else would you want to know? Ask JR. I just threw out some of the stuff, but going back to that list of issues that I had earlier on you know, um, who else is he eating with? What's his training regimen like? Does he have cheat meals? What does he know about his eating disorder? What does he know about treatment for eating disorders? What's it like for him to go back and forth to home or Mexico and back? Um, what's his experience with food insecurity? How anxious is he? And I tend to work from my foundation and background was much more relational and psychodynamic. So I tend often to build into this stuff, like who are you talking to about this? Who knows what you're dealing with? Who do you turn to when you're having a hard time? And again, that can be gendered because I think we assume that women, again, rightly or wrongly, but this is the stereotype that women sort of are going to connect to other people more easily than men. And I think many men still culturally are a little inhibited about reaching out and like letting other people know when they're having a hard time. So obviously, if they're in a therapy office with you, they're in a environment already where they feel like this may not be what I normally do. So you have to sort of be aware of that as a dynamic in the work. Okay. We'll sort of stop here and just these are, I guess, the QR codes for your evaluations. But again, we have 5 minutes or so left for me to take any questions you have, and I'd be really eager to hear anything you have to say. But thank you for your attention, and sorry for the slide glitch.
Thank you so much, Dr. Donald. Um, it was definitely a great presentation, and we are definitely eager to continue collaborating with Nita. For everyone who's still watching, we are going to be providing the certificate of attendance probably next week, 5 to 7 business days. Please fill out our evaluation, which is going to be very important for us to see what you guys thought about today's webinar, but it also going to provide us more feedback on other topics that you would like for us to provide. We will also be sending the evaluation with the certificate of attendance. And today's presentation is going to be uploaded to our YouTube channel and also to our webpage, and you can find it using the same title of today. Dr. Donner will have very good feedback from the participants in the chat box.
Yeah, I'm just checking that now. Thank you. I appreciate your feedback, and I'm just trying to see if there's any. Yeah. Somebody mentioned I come from a Hispanic Asian household and came to the States when 15. I'm glad I attended this training. Well, I hope it was helpful that you know about sort of the cultural shifts and what it's like to make those transitions.
We still have a few more minutes if any of
Yeah.
you have any other questions. I am
Anyone
also going,
think of
yeah.
anyone think of a case they've had even recently where they sort of were surprised to find that their male patient had some eating issues? Well, I'm working on another project where we're really looking at training for psychotherapists around men with eating disorders in general. And sort of looking at some of the research data, but in the US, the vast majority, and I mean like 80% or more of the treatment provided to people with eating disorders and disordered eating is provided by people who don't have any training in eating disorders. So most of the people who have eating issues are in therapy, usually for something else. Like, so it's sort of part of the package of what they're dealing with. And I think where things have changed, thankfully in the direction of are really being alert to these issues for young girls and young women, teens and women. I think we've pushed ahead in terms of our sensitivity to picking this up in boys and men, but spread the word. These are definitely issues that boys and men are dealing with. They're definitely issues that boys and men across the world are dealing with. So if you can sort of ripple out from what we did here today and just sort of make sure your colleagues are at least asking the question, or listening carefully for these sorts of issues with their boys and men, that would be important.
Thank you so much, Dr. Donald, for the vital information you have shared today. If there are not any more questions or any more doubts about this topic, I guess we can end today's webinar, but for sure, we will continue doing this type of webinars and providing this type of trainings in the future.
Thank you very much and appreciate the invitation and hope it was helpful. Thanks.
Yeah, have a nice day.
Bye, you guys.